Mochel, and I am TMA's immediate past board chair. We're especially excited about our upcoming Myositis conference, MyoCon 2025, which will be held in Dallas, Texas, from September 18th through the 21st. We hope you will be able to attend and connect with others in the myositis community. For those of you joining us for the first time, we'd love to know where you're tuning in from. Please feel free to share your location in the chat box. It's always inspiring to see how far this community reaches. Just make sure your message is going to everyone, not just the host and panelists. You can adjust that by clicking the down arrow or chevron and the blue button at the bottom of your chat box. Since 1993, TMA has been dedicated to improving the lives of those affected by myositis, funding innovative research, and increasing awareness and advocacy. We envision a world without myositis, and we work every day to get closer to that goal by providing education, support, and resources to the myositis community. I'd like to thank our sponsor for today. Thanks to our sponsor, Bristol Myers Squibb, for making today's event possible. Thank you so much for your support. So how about a few quick housekeeping notes? We've heard that the Ask the Expert webinar series is one of the most valuable ways we engage with you. Each session features experts from TMA's Medical Advisory Board or other distinguished members of the myositis community, and today is no exception. We encourage you to take full advantage of this opportunity. All I ask is ask your questions in the Q&A box. The chat, if you put the questions in the chat box, they sometimes get missed. So questions go in the Q&A box, and chat goes in the chat box. And remember, you can what you learned today, you can share with your team, family, friends, and others to help educate about myositis. I would say, if for those of you who missed, or if there's something you'd like to rewatch, this webinar is being recorded and will be available on TMA's YouTube channel on the 1st of next month. And bottom bullet there, I think, is important. We would ask you to appreciate you filling out the surveys. It really does help us tailor our content. And one last bullet that matters, disclaimer, yes, this is not medical advice. I guess take this with a grain of salt. So each of these things have to be tailored to your own clinical situation. Okay, being from Chicago, I'm excited to dive into today's session. It is my pleasure to introduce two of our distinguished experts from USC, or the University of Chicago. We have Dr. Iazsmin Ventura, is an assistant professor of medicine and director of the myositis program. She's currently leading, I should say, a CAR T clinical trial focused on innovative treatment options for myositis. And she's also a past board member for TMA. And also Dr. Satyajit Kosuri is an assistant professor of medicine and hematology oncology at University of Chicago. His research centers on stem cell transplants and novel immunotherapies. So we have both of these experts, and I believe Dr. Kosuri is going to go first. So thank you both for taking time out of your busy day to join us.
Okay, great. Thank you, David. I'm going to go ahead and share my slides here. And then you can let me know if you see them okay. Okay, great. So thank you, everyone. As David mentioned in the introduction, my name is Satyajit Kosuri. I am a cellular therapy physician at the University of Chicago, and I work very closely with Dr. Ventura on this new venture in the field of autoimmune disease, which is using CAR T-cell therapy, which is kind of a novel cellular therapy in this space. So I have no disclosures or conflicts of interest. Anything that I'll be talking about will be either approved or within the context of a clinical trial. So my goal here really is to go over some of the very basic or fundamentals of CAR T-cell therapy in general, to give you a sense of what the technology actually is and how it works. And then we'll talk about a little bit about the patient journey, how it looks when a patient is set up to undergo CAR T-cell therapy from a general sense. And we'll talk about the potential toxicities of this modality, which is something of significant interest to everyone when they hear about these novel therapies. And then I will pass the baton over to Dr. Ventura, who will talk more in detail about myositis specifically within the context of CAR T and other therapies. So I think we start off with the definition, cellular therapy. When you hear someone say they're a cellular therapist, it's really about using living cells instead of the traditional approaches to treat various disorders. In our world, or the world that I come from, chemotherapy and radiation therapy are kind of the common approaches that we use to treat people. And so you can see here to your left, there's all sorts of different types of therapies or modalities that fall under the umbrella of what we call cellular therapy. And the one that we'll be talking about specifically, the full name here is chimeric antigen receptor, and that's what makes up the CAR and the CAR T cell. And so here's pretty much a basic definition. As we know, and many of you are familiar in autoimmune conditions and even cancers, we're always looking at the immune system and the dysregulation of the immune system. So CAR T cells are T cells that are modified or engineered to recognize specific antigens on aberrant cells, whether these are tumor cells in our world or B cells in the autoimmune world. And once these T cells, these engineered or modified T cells, actually recognize these irregular cells, they activate and they proliferate, and they eventually result in significant and durable destruction of the abnormal cells. So CAR T cells have always been considered what we call a living drug, as they tend to persist for long periods of time. This may be different in our world, in the chemotherapies that we use, or in the autoimmune disease realm, using other various immune suppressives. And CAR T cells right now, from a technology perspective and a practice perspective, are generally created from the patient's own blood cells. Although we do have the ability to produce what we call off-the-shelf or third-party CAR Ts. So when we compare CAR T cell technology to the traditional methods that we have been using in various conditions, we know that CAR T cells can be much more specific. So if you think about the analogy from the world of cancer medicine, when we give someone chemotherapy or radiation therapy, we can think of it like a napalm. It's destroying all the bad guys, and it's also getting rid of the good guys. Whereas CAR T cell therapy is much more specific and focused, so that's an advantage. There's memory because, as we said, these CAR T cells tend to persist. So even though someone has been through the hospitalization and the recovery, their treatment continues even after that, which is an advantage with this type of modality. And there's a universal type of characteristic. And when I say that, is that you have a platform that can be adjusted to different targets. So you can go after different types of abnormal cells and abnormal conditions. So we can treat lymphomas, we can treat autoimmune conditions, and we can even treat, or we're having clinical trials in neurologic diseases. So it's a really applicable platform that's pretty wide here. So I'm not going to go through all of this, but this is just to give you a general sense of the progress that has been made since 1980 in cellular therapy. And you can just kind of focus here towards the end of the slide. In 2017 or so, we started to get FDA-approved CAR T cells in the realm of blood cancers. So the idea of CAR T cells started around in the late 80s into the 2000s. In 2010 to 2012, we started to have really important clinical trials that were being undertaken for various hematologic malignancies. And then, as I mentioned, in 2007 to 2017 to the present, we have multiple FDA-approved CAR T therapies for various blood cancers. And we have other clinical trials for solid tumors, rheumatologic indications like myositis, and then neurologic indications. So I think it's always nice. I mean, I can always talk to you about how CAR T cells work, but I always think it's nice to have some sort of graphical representation, to have an understanding of how this technology is used. What you see here on your left-hand side is your normal T cell that we can think of that has been collected from the patient. And that T cell undergoes a first step. When we say engineering, what is happening is there is an insertion of viral DNA because it's easy to do. And what this viral DNA does to the T cell is that it gives it instructions. And the instructions here in CAR T cell therapy is to create and express a very specific type of receptor, or like an anchor, you can think of it, on the surface of that T cell. So now that T cell has changed, and this is kind of the engineering component when you hear that you have engineered T cells. So these T cells, after some lymphodepletion, which we'll talk about in a few slides, is then these T cells are infused back into the patient, and they have a very specific target now. They have a very specific duty, which is to identify the antigens or the targets on these irregular cells for which it was created, whether it's a tumor cell or B cell in autoimmune conditions. And it's able to recognize this target cell much better, and much more intensely than the regular T cell. And so once it engages with this abnormal cell, what happens is that it activates, and there's a whole bunch of inflammatory signals that are sent out, which allows the CAR T cell to multiply and expand. And there's multiple other cytokines that are released, and eventually you get the killing of that abnormal target cell. And so that's kind of the way that a very crude representation of how CAR T cell therapy works in the human body. So what you see here is kind of a graphical representation of that receptor that the T cell has gotten instructions to make and to place at its cell surface. That red line there is the lipid surface of the cell. And on top in the orange is where the CAR T cell attaches. And I just want to highlight here what's going on underneath the cell. There's something called a co-stimulatory domain and a signaling domain. And you don't have to understand all the details of this, but I think the general takeaway is that the co-stimulatory domain and the signaling domain are important because it allows for the expansion and the persistence of CAR Ts once they're actually in the human body. Now, so you understand kind of the basics of CAR T and the way it looks and the way that it works, its mechanism of action. Why have we been on the blood cancer side so excited about what this therapy, what we thought it could do, and then what it actually has done in the last 10 years or so? So I just want to take one example from the blood cancer world. So what you see here is a population of patients with the diagnosis of acute lymphoblastic leukemia. And acute lymphoblastic leukemia, once it's been treated, in those patients, if they have relapsed or they are refractory to treatment, they don't have a very good prognosis. In fact, the prognosis is pretty horrible. And this is basically what these curves are showing. And over time, this was one of the target diseases for CAR T cell therapy. And I'm just showing you here, I'm highlighting basically what we saw in the early clinical trials using CAR T cell therapy in this very difficult to treat disease. The CR rate stands for the complete response or complete remission rate. And you can see here it's close to 90% in almost all of these studies. And this is a really big deal because I call this from hospice to hope, right? These are patients previously, prior to CAR T therapy, where we were having hospice discussions. And to be able to have some sort of modality where we can go from those hospice discussions to saying, okay, we can get you into remission, and hopefully that can be a long-term remission, that's a really huge turnaround. And so that's why the technology of CAR T in general has been something that we've been very excited about. And now we have that same excitement as we're going away from or going out of the oncology space into other rheumatologic and neurologic spaces. So I just want to quickly touch base here about what it looks like for the patient journey. So I think it's a very kind of basic representation that we can break up into three big categories or broad categories. So the first experience that the patient has once they have been thought of as a good CAR T cell therapy candidate is a situation called apheresis. And apheresis is the collection of the patient's T cells that we will then send off to the company for them to do engineering. And so when we speak about apheresis, this is usually something that is relatively well tolerated. It's about a 1-day procedure, or it happens over the course of a few hours, and it can be done through IV. IV in each arm, or if people have veins that are not very readily accessible, we use a central line in the upper chest, and we collect the T cells that way. So after the apheresis procedure is done, the patient can go home and can do all regular activities. If they need to go to work the next day, they can go to work the next day. So it's not a very invasive type of situation as one may think. The second part of it is just kind of a waiting part where once the T cells have been collected and they get shipped over to the company or the sponsor to make the CAR T cells or to engineer them like we saw in that one graphical representation. It's just a waiting period where in the case of autoimmune conditions, the patients will continue to follow up with Dr. Ventura and team and have their disease under control. And then it takes a period of about, every product is different for various indications, but I would say in general, 4 to 8 weeks or so for this engineering and quality control process to occur, and for the sponsor or the company to send those cells back to, for example, the University of Chicago. And then at that point, patients are ready to undergo the lymphodepletion and infusion of the CAR T cells, which we'll talk about here in a second. And so this is just kind of a more detailed representation of what I was talking about. The timeline varies basically. So I want to touch upon after the cells are collected, we're using this terminology lymphodepletion. And a lot of times what this means and what you'll hear doctors talk about is chemotherapy. And so I think that that's a scary word for patients who, in our blood cancer patients, it's kind of standard. They hear chemotherapy and it's just part of the process. But for patients where indications or chemotherapy, that term is not regularly used, it can be a scary thing to hear. However, what I will say is that this is not the classic chemotherapy that you think about when patients are getting treatment for lung cancer or leukemias or that type of thing. And it serves a different purpose. So we call this lymphodepletion. And what this means is that we are suppressing the patient's immune system at that time to allow for the easy infusion of the new CAR T cells. So it creates a favorable environment by potentially eliminating suppressor immune cells like T regulatory cells, and it can upregulate in cancer patients tumor immunogenicity, meaning it makes them more sensitive. And in general, irrespective of the indication. It can reduce other immune suppressive agents. So the patient, once they're infused with CAR T cells, they get their lymphodepletion, they get infused with CAR T cells, and then they get admitted to the hospital for observation at this time. And the reason for the observation period is really to look out for various potential toxicities. One thing that I will say here is that so far, what we are seeing and what's being reported is that the potential toxicities, the acute ones especially, in rheumatologic indications have a lower incidence and also a lower intensity than what we saw very early on in the blood cancer world. So I think that that's something that is good and important, but it is important to talk about them. One of them is called cytokine release syndrome, and the other one is called ICANS, which I will just basically define as a neurologic toxicity, and we'll go into some of the details here a little bit more. So cytokine release syndrome is a systemic inflammatory disease that happens after the infusion of the CAR T cells. And if you remember the mechanism of action graphic, when the CAR T cells and the, in this case, abnormal B cells get together, there is a release of all of these inflammatory cytokines or signals in order to both recruit more immune cells to the site, expand CAR T cells, and also to kill the abnormal cell. And so when this is happening, you get this very complex inflammatory cascade. I like to break it up into 3 steps here. You can see the CAR T cells in step 1 attaching to the B cells, and you see all of these various chemokines or inflammatory cytokines like interferon, TNF. There's one in particular that I just want you to keep in the back of your head called interleukin 6. Interleukin 6 is a very important driver in the process of cytokine release syndrome. And then in step 2, you can see here recruitment of the patient's own immune cells coming to the site to kind of help out the CAR T cells. Step 3 is endothelial cells, which some of them can be damaged and also cause the release of various inflammatory cytokines. And so if you were to ask me, how does a patient present when they start to develop cytokine release syndrome? Well, there's 3 kind of major hallmarks of CRS. Fever is by far the most common, and it's number 1. So it's the smoke for the underlying fire that's happening within the patient's body. Sometimes the patients will get a little bit hypotensive as a result. And then the last one that we don't see as often anymore is hypoxemia or having a low oxygen saturation. It can affect various organ systems here. And it usually occurs within the first days of infusion because that's when the CAR T cells are expanding. So cytokine release syndrome usually happens first, and then neurologic events, that ICANS definition that we talked about, can happen kind of concurrently or towards the end or after cytokine release syndrome. So if someone were to develop cytokine release syndrome, what do we do about it? So one thing that I can say is that we have a lot of experience managing cytokine release syndrome, given our experience in the blood cancer world. And we have an FDA-approved medication that is also used in the clinical trials for indications outside of blood cancer. And the name of the medication is called tocilizumab. And tocilizumab is a medication that goes and it sits in the receptor where IL-6 is supposed to bind and allow that inflammatory cascade to continue. And so we have a very good drug, and it is very effective. And we have various options if patients need more than 1 dose of tocilizumab, and we call it TOCI for short. So we'll jump very quickly to ICANS. ICANS is the neurologic signs or symptoms that can occur within the first few weeks after CAR T cell infusion. It may be directly associated with CRS, it may not. And the pathophysiology is very complex and is not clearly understood. But if we have a hypothesis here, what you can see here at the very bottom of the slide is this these tight junctions. This represents the blood-brain barrier that separates the body from the central nervous system. You can see above here is that CRS type inflammatory situation that's going on. And if there's any damage or disruption of the blood-brain barrier, it is believed that this inflammatory process can find its way or travel into the central nervous system and cause an inflammatory situation happening within the central nervous system. So it's basically trafficking of the systemic cytokines and CAR-Ts into the CSF. So if that were to happen, what do we see and how do we treat it? Well, we actually have something called an ICE score. An ICE score is a writing sample and various cognitive questions that test the patient's orientation. We do this multiple times a day, and we give patients a score of 10 for perfect ICE score. And then as it keeps going down, then we start to have an understanding that, okay, something may be going on in the central nervous system. So usually when people have an ICANS grade 1, where their ICE score is barely below 10, we just kind of watch them. Sometimes we will actually give them steroid therapy, especially as the ICE score starts to come down in that 3 to 6 point range. And this is kind of it's not as clear. We kind of go with a little bit of our gut. It doesn't have to be so 3 to 6 or 7 to 9. We have a sense of how the patient's doing. If the patient were to need therapy, the main therapy for ICANS is corticosteroids. So we use dexamethasone either once, or if the patient has persistent ICANS, we'll use it kind of around the clock until the symptoms improve. One thing you'll see here is ICANS grade 3 and grade 4. I will say that it has been, as our experience in anticipating and treating ICANS has improved over time, we very rarely see patients with grade 3 and grade 4 ICANS. That's a more serious thing that happened very early on in the early trials with blood cancer treatments, CAR-T for blood cancer. Sometimes we would have done lumbar punctures to kind of decompress the CSF. And some of these patients very rarely even had to go to the neurologic ICU. So far, that has not been the case. That has not been what has been reported in the rheumatologic indications. So that's good. So I will close here with this take-home points and pass it off to Dr. Ventura. So CAR T-cell therapy is a platform which can be used in many different disease states. We started off in cancer medicine. We're now in autoimmune diseases and neurologic diseases. And so there's a lot of excitement regarding the efficacy of CAR T-cell therapy in rheumatologic indications like myositis. CRS and ICANS associated with CAR T-cell therapy is complex and multifaceted and requires in-hospital intervention. However, like I said, and I emphasize, we have many years of experience in knowing how to manage them, and we do a much better job than we did very early on in the blood cancer clinical trials. And at this time, we have an expectation that these particular side effects are less likely to be as prevalent or as serious in rheumatologic indications. But of course, the caveat is that we're very early on and we need more time and more data to see how we compare. But overall, we're finding that these treatments in patients with myositis and other rheumatologic indications are very tolerable, and they have a decreased hospital length of stay when compared to CAR T-cell therapy in the original blood cancer indications. So thank you very much for your attention, and I'll stop sharing my slides and pass it on to Dr. Ventura.
Well, thank you, Dr. Kosuri. When Dr. Ventura is getting teed up here, just a quick ballpark for those two, CRS and the ICANS, ballpark percentages, like what out of, and granted, this is just every disease state may be different. Just ballpark, what percentage of the time are you seeing these sort of complications?
So I will break it up into what we have seen at our center in blood cancer and then what we have seen at our center in rheumatologic indications. So far with blood cancers, very early grade and stage CRS happens in almost every single patient. It's almost a guarantee. But the good thing is with blood cancer, in the blood cancer space, we're looking at grade 1 and grade 2. The ICANS happens, I would say probably it's a flip of a coin. But so far, out of the 3 patients that we have infused in rheumatologic indications, and Dr. Ventura can also fill in details, we've only had 1 patient with a very early grade CRS that didn't need significant systemic therapy. And that kind of tracks along with, you know, the data out there. When we break it up according to various rheumatologic indications, it's kind of a mixed bag, but I would say greater than grade 1 or 2 CRS is less than 50% in the patients, and Dr. Ventura can also chime in on that percentage.
Appreciate it. I'll turn it over to Iazsmin. Yeah, go ahead.
Yeah, we can talk a little more about this, but it is rare that we are seeing more concerning ICANS and CRS episodes. Most patients, if they develop any problems, they usually do just the mild form of CRS at this point, which is good news. Okay.
Yeah.
Let me just get my slides here.
Well, and keep it in the perspective of going from hospice to hope. Okay, so
Yes.
so put that for those. Yes, these things can be scary and frightening, but when you look at the data that Dr. Kosuri was showing, I mean, to go from hospice to hope, an incredible improvement.
Can you see my slides?
Yep.
Yes.
Awesome. Okay, wonderful. Now that we have reviewed as a tour de force from Dr. Kosuri what CAR-Ts actually are, how are they engineered, and what entails for a patient to actually receive this treatment, I'm going to focus the next few minutes of our presentation on myositis. First of all, why are CAR-T cell therapies now an interesting possibility for patients with myositis? I think this is important for people to understand why we're entertaining this treatment for myositis patients. So we believe now, and this is a lot of work from the research community in the myositis field in the last 20 years, that one of the hallmarks of idiopathic inflammatory myopathies, which I'm going to abbreviate as myositis or IAMs for the rest of the lecture, is the fact that most patients have some autoantibodies. So I would like to remind ourselves that autoantibodies are basically proteins that our immune system produces that were supposed to keep us safe from infections and cancers, for example. But these antibodies instead are targeting self. They are targeting self proteins, so proteins inside our own cells. So they are abnormal. They shouldn't be there. And we know that myositis-specific antibodies and associated antibodies have been associated with several subtypes of myositis. I'm going to give a few examples here, and I'm sure people in the audience can relate to that. So some patients with myositis may be found to have an MDA5 or an MI2, for example. Antisynthetase syndrome, the most common one is anti-Jo antibody, and we have other 7 as well, anti-PL7, for example. The immune-mediated necrotizing myopathy, we have 2 antibodies that have been described, the anti-SRP and anti-HMG CR antibodies. And these antibodies nowadays, they are not only used for diagnosis, they are very helpful for physicians to get the right diagnosis for patients with myositis, but they also correlate with clinical manifestations. For example, we know that patients with MDA5, they have specific rashes. They are quite unique to MDA5, and they're more likely to develop lung disease as well. So they really correlate with what we expect to see in a patient when they come to the clinic. They also give us an idea about the prognosis. Oh, some antibodies in myositis can be associated with cancer, and we need to be very mindful of that and making sure that we are screening patients from top to bottom not to miss any cancer. And most importantly, very recent research coming from centers such as the NIH have recognized that these antibodies had a potential disease-driving role, meaning they are pathogenic. They're actually causing the disease. And as these titers go down, the amount of antibodies that can be identified in the blood goes down. It seems that disease is also less active. Perhaps this is the moment when researchers thought that, maybe targeting these antibodies is the way to go. And by addressing the cells that produce these antibodies that we believe are causing disease, we may be able to ameliorate myositis in patients who have very severe disease. So that's the thought process, and that's the reason why CAR-Ts have been interesting now. And this is just a table that kind of summarizes, again, the many antibodies that have been recognized. Those are myositis-specific antibodies in the field. I want to mention that about 20 to 30% of patients with myositis nowadays don't have a recognizable antibody. This is probably because we have not yet identified what antibody they have, and many researchers around the globe are working very hard to identify these other antibodies that may be missing from this table. Okay, so where are these autoantibodies coming from? They're coming from B cells, and the B cells are the cells that, as Dr. Kosuri mentioned, abnormal. They are misfunctioning. And we believe that addressing B cells, we may be able to help providing control of myositis. I just want to get you a little bit back from your classes in biology. Please hold in there. We have the pluripotent stem cell in your bone marrow. This cell is basically the parent cell of many cells that will populate your blood, your spleen, your lymph nodes, and some of the cells will differentiate in this B cell, also called B lymphocyte. These B cells also have their family of their own, and they mature over time. They are initial B cells, pro B cells. Some of them later on mature to become plasmablasts, and later on, some of them may become senior cells in the family called plasma cells. And as you can see, these cells are actively, this is their duty in our immune system. They're actively producing antibodies. And for reasons that we don't fully understand right now, some of the cells are pathogenic, they are problematic, and they are producing those antibodies that, again, are not targeting a virus, they're not targeting a cancer cell, they're instead targeting self. They're targeting some other proteins in our muscles, in our lungs, in our skin, and causing disease. I want to mention here some of the cells, when they become senior, and this is important for our discussion, may get out of the blood and reside on the spleen, lymph nodes, bone marrow, and inflamed tissue as well. So how have we so far addressed B cells in inflammatory myopathies? Again, this is not a new thing. We have been targeting B cells for quite some time in myositis. Most of you may be familiar with a medication called rituximab that is attacking here the CD19, this tag that is in the surface of B cells, the younger cells in the B cell family. We have this medication called belimumab, which is a medication that has been used for lupus, but has also been used sometimes for patients with myositis. And belimumab, it is targeting these specific receptors that help them to thrive in the blood of all cells in the lineage as well. And we have this other medication that is commonly used for patients with multiple myeloma in hematology. And this medication here targets the older cells, the most senior cells in our B cell family. So as you can see, this is not a new approach. We have been using B cell targeted agents for quite some years in patients who have more severe types of myositis. What is new now is that we're using this new technology that Dr. Kosuri mentioned that has been quite successful in transforming the world of leukemias, for example, and lymphomas. And now we're using CAR-T to target the same cells. So we believe, again, that these abnormal B cells that are producing these antibodies need to be destroyed somehow. And instead of using these other agents that we have used for quite some time, we're now using CAR T cells. And this is another type of CAR T as well, targeting specific tags in this lineage of B cells. This is just another, again, graph showing how much the field has evolved in autoimmunity. Not only patients with myositis are being treated now in clinical trials, patients with lupus, systemic sclerosis, rheumatoid arthritis, patients with neurologic conditions have also been getting this medication through clinical trials as well. And even patients with Crohn's disease are now being considered for specific types of CAR Ts. Again, all these CAR Ts are a little bit different here and there, the way they engineer. But the main target, as you can see here on your left, it is that abnormal B cell that is producing these abnormal antibodies. Okay, so what have been the results so far? I think this is the biggest question that I have from patients in the clinic and here in the audience as well. This is a summary from a paper that was published now in 2025. And be mindful, this is not at all comprehensive in a setting that more patients than these few patients here have been infused with different CAR Ts all over the world, but these are the patients that have so far had the outcomes published in the medical literature. So we have patients with necrotizing myopathy, juvenile dermatomyositis, antisynthetase syndrome, also dermatomyositis as well. And most of these patients so far, a few months or a few years after the infusion, up to 3 years after the infusion, most of them have, thankfully, been drug-free. They have achieved drug-free remission, which is something unheard of in our community. Okay, so far, this is not something that we usually appreciate. Most patients who have severe disease, severe types of myositis, will need some sort of immunosuppression for a lifetime. There are patients, however, they have relapsed in this 1 to 2 to 3 years that they have been followed. And some of these patients have gotten back on medications that are also familiar to most of patients in our audience. Mycophenolate, azathioprine, for example. So long-term remission may not be for everyone, and we are trying to understand why some people may go into remission, at least so far. Remember that this treatment has not been used in clinical trials for too long, so we have limited data. We have just a few years of the early patients who were infused, so we don't know if they will continue to be in remission 5, 10, 15, 20 years later. But I just want to highlight here, we have a busy slide, but I want to focus on this number B here, the graph the letter B here in the graph on your right upper corner. This is the CK level. Most of you are familiar that we monitor the CK levels closely for most types of myositis. And you see how elevated it was. This dotted line was the normal range. And here, this color line are all the treatments that this patient received. Eventually, this patient received in 2022, the CAR T, CD19, and then the CKs dropped to normal levels. Amazing, patient is in remission. But later on, about 9 months later, you can see the CKs start creeping up again. So the patient was no longer in remission. And after that, this patient received daratumumab, one of the medications I discussed with you a few slides ago. And then we received another CAR T called BCM CAR. And then finally, the CKs again normalized. So again, we don't know yet why that's the case, why some patients may get into remission for a few years so far, and why some patients have been described in the literature that have developed recurrence of disease or have been refractory to CAR Ts. What about side effects? Again, Dave just mentioned, hey, how many patients? It's hard to give a percentage because, again, most of this data is unpublished at this point. We are talking about clinical trials that are ongoing. But Dave, what I can reassure you is that most patients don't develop any adverse events. And when they do, the cytokine release syndrome that Dr. Kosuri was mentioning is usually grades 1 or 2. So mild, these patients may experience some fevers. They may notice that the blood pressure is a little low, and they are easily managed in the hospital setting with IV hydration. And most patients, again, may not require to receive any additional treatment. And if they do, we are very ready to treat these patients and avoid the cytokine release syndrome to continue to progress. So short answer is most patients don't develop any side effects, and the ones they do usually have mild ones. The same thing with the neurologic toxicity related events. We need to acknowledge that these patients are at risk for infections, and this is also something that is very familiar to our patient population, right? Most of us here treating patients being treated for myositis are using immunosuppressive medications that by definition decrease the ability to fight infections, and these patients, a lot of them have experienced opportunistic infections during the course of treatment. So this is something that is also expected. And depending on the CAR T cell therapy that is being used, especially if they target those senior B cells in the B cell family, they may also lose the ability, the vaccine memory that they had developed over time when they were vaccinated or exposed to several viral diseases when they're younger. Okay, now that I had reviewed with you why this medication is interesting for myositis, what so far has been the very limited experience of our community, and what are the concerns in terms of side effects, I need to share with you that I have many unknowns, and these unknowns are not only from my side as a researcher, but also for patients and other researchers around the world. What are the antibodies? What are the actual targets that we need to focus as we continue to evolve in the CAR T cell field? How different patients with different autoantibodies may respond to treatment. Is targeting the B cells alone the right way to treat these patients, depending on the subtype? What about the long-term efficacy? We don't know yet how these patients are going to be 15, 20 years from now. Are we better off infusing engineered T cells that we got from that same patient, or are we better off using T cells that have been collected from healthy donors? Can we use preconditioning, that a small amount of chemotherapy that Dr. Kosuri mentioned for everyone, or should we try to avoid those? What are the actual, who is the most likely to respond to CAR T cell therapy? Patients with early disease, newly diagnosed, or are we talking about only refractory disease, which has been the focus of the clinical trials we have available so far? Pediatric or adult patients. Again, pediatric patients, if you think about it, is like those are the ones who really need to get better soon, right? This disease not only compromising their ability to go about their day and be functional, but also the ability to evolve cognitively, emotionally, physically. So should we be targeting more and devoting our efforts to treat pediatric patients? But at the same time, if we're treating pediatric patients, what are the concerns in the long term? Are there any? And in terms of subtypes, again, I'm going to talk a little bit about this in the next slide, but do different subtypes, again, benefit in a different way? And I believe this could be the case, and that may be the impact the patients we're including in clinical trials. What are the healthcare costs, right? We're talking about a treatment that may cost about $500,000. So if we were to upscale this, how can we make this feasible, especially in a healthcare system such as the one in the United States that is ballooning every year? Again, long-term side effects are unknown. And are we talking about one-time infusion or several infusions if patients are to have recurrence of the disease after they get better initially from CAR T? So many unknowns, and that's the reason why this is not something that is being done off shelf as part of the treatment algorithms for myositis. This is the reason why this is a clinical trial, or I'm going to say many clinical trials, because we yet don't know many answers to these many important questions. And those are the things that any patient needs to consider when entertaining the possibility of volunteering to a clinical trial. I received this question quite a bit. I'm sure many here in the audience are also interested to know, what about inclusion body myositis, Dr. Ventura? We haven't discussed any, I haven't heard anything about inclusion body myositis in CAR T. To date, there is no published data on CAR T cell and inclusion body myositis. The current clinical trials in using CAR Ts have not included patients with inclusion body myositis. And many of you may ask, why is that the case? It's because we still know very little about the pathophysiology, how IBM actually develops. This is probably a combination of inflammatory and muscle degeneration that happens. And the truth is that depending on which one is more important individually to a patient with IBM, this treatment that is targeting now, most of the time, B cells, may not be efficacious. So unless we really understand what should be the target, and I don't think that we necessarily know for now, we have some ideas of immune cells that could be targeted for the treatment of IBM, but we're also waiting for more data to be published on that. We don't know if we'll have a target to use in CAR-T for the treatment of IBM. And again, time will tell as we get more results from other types of myositis, if they can inform us on how to better treat inclusion body myositis. And again, other clinical trials are also helping us to better understand what should be the target for inclusion body myositis if we were to entertain CAR-T cell therapy in the future. So I'm going to open now for discussions and questions.
Well, thank you, Dr. Ventura. I think, and Dr. Kosuri, lots to get to. So I think in our remaining time, I'll tend to cruise through. So I think contraindications, put it like this, I will emphasize, take a step back. This is a very promising, as a non-educated, rheumatologist or oncologist physician, this is a very promising therapy that is in its really early stages. And I think what Dr. Kosuri mentioned something, when they were learning how to do this for people with blood cancers, they had a real problem with this, or a potential problem with this neurological problem, but then they figured it out pretty quickly. My point is it speaks to these, we're learning, okay, and it speaks to why isn't this just available anywhere? I hear this all the time, and it's a good question. I think this speaks to how this is complex, and the more you deal with things like this, the more you can understand, the complications and when they arise. It is in its infancy. So I guess good question, Karen asked. When is CAR-T? What are contraindications? Is there anybody that you wouldn't, IBM? I think we've addressed. Different pathophysiology, we all know it. Unfortunately, for those of us, including myself with IBM, not ideal. But that being said, any contraindications for CAR-T therapy? At this point.
So at this point, yeah, I'll mention in terms of the myositis perspective.
Yeah.
So at this point, Dave, most of the clinical trials are enrolling patients who have refractory disease. That means that patients who have failed the most standard therapies that we use. So most patients have early disease or have mild to moderate disease have not been included in these clinical trials as of now. The other thing I'm going to mention is that the other patients who have not been considered for these clinical trials from the inclusion perspective is patients who have long-standing disease. They have a lot of damage, and they are very debilitated because of the damage. Their lung disease has a lot of scarring. Their muscles have become atrophic, but the disease is no longer active. So we are not seeing a lot of inflammation in their muscles, skin, or lungs, for example. So those patients have not been included in most clinical trials. They're ongoing with myositis. Satya, do you have anything to say specifically about CAR-Ts in general that we would like to avoid?
I would say just kind of in general, with these clinical trials, they have various inclusion and exclusion criteria. One of the things that's been the case kind of across the board, irrespective of the indication, is that, as Dr. Ventura is mentioning, you have a disease-specific inclusion, exclusion, and then making sure that people are actually fit enough at this time when we're using things like lymphodepletion to be able to withstand kind of what happens with low blood counts and the recovery from that, not having active infections when they come in, like chronic infections. So those are all things that put people at risk from the technical aspects of the recovery after a little bit of chemotherapy.
Yeah, makes sense. So at this point, it's only available in a clinical trial.
That's right.
For myositis patients, just so we're clear to everybody on this call, it's only available in a clinical trial, and I think that you can see, why that is. Well, I'll try to fly through these last. If a patient does have a CRS reaction, do you see in general that the treatment is still effective, or is?
And,
I mean,
we're talking
speaking,
about the,
yeah, I took what subset of patients, right? The myositis patient subset is smaller, but I guess, yeah, you have a lot of experience at Dr. Kosuri in the
yeah, so
non-myositis patient.
what I would say is that in general, irrespective of what the diagnosis is, the way that so far, the way that the CRS has presented is pretty much I would say presents in a uniform manner because the inflammatory cascade is very similar in every patient and kind of the driving forces behind it. And so when we're able to treat these patients, it's been effective kind of across the board with our approach. The question, and it's much more rare so far in the autoimmune indications, is that if we use the FDA approved or the approved medications to treat CRS, does it stop there or do we need to continue? And that goes into, using more doses of this drug, called tocilizumab, or plus or minus using other anti-inflammatory agents like steroids or cetuximab. But usually the approach that we have used and that we have built from the blood cancers is something that's been very effective over the years.
Sounds good. Would CAR T therapy be an option for people who have had a past history of cancer?
Yeah, that's a good question. At this moment in the clinical trials for myositis using CAR T, patients with history of cancer have not been included unless is a squamous or a basal cell carcinoma of the skin. I wouldn't be surprised as this medication moves forward and we learn more and eventually becomes part of the algorithm for treating patients with myositis in general, that will be able to include patients who have history of cancer as well. At this moment, though, as a clinical trial, we don't.
And have patients been in the trial that have not tested positive for any of the myositis antibodies?
Yeah, so the juvenile dermatomyositis patient that I mentioned in the table was tested negative for the myositis antibodies. I think one of our myositis patients, the juvenile dermatomyositis patient that is being infused at the University of Chicago, is also negative for the antibody. But for other patients in the other subtypes, it is so far recommended, and is actually mandatory for patients to have a positive myositis antibody, with the perspective that, again, by targeting that cell that is producing the abnormal antibody, we hope to get the disease under control.
Yeah. Last question. Thank you. My pulmonologist explained that the off-the-shelf CAR T version, and that was appealing to me. The preparation didn't seem as intense or lengthy. I'm 70, receiving IVIG, 3 days every month. Was repeated, may have to repeat it down the road. Any brief comments on that? Good question.
Satya, do you want to get this?
Yeah.
Sure. So I'll talk about the historical perspective really quick of off the shelf, and then I'll go to the question here. So what I'll say is that for off the shelf CAR T, the idea is two things that could be an advantage, or one main advantage is that it's much quicker in the sense that when we collect the T cells from the patient themselves, the manufacturing time, is on the order of the weeks that we talked about. It could be up to 6 to 8 weeks, in some cases 4 weeks. So different trials for different indications. Some are quicker, some are longer in regards to that. With the off-the-shelf CAR T, the idea is you do not have to bridge from the collection to the infusion or the lymphodepletion and the infusion of cells. So it's a much quicker time frame that you get to infuse or get to CAR T. So that's kind of the major advantage. One thing that I will say from the blood cancer perspective is that we have not seen necessarily a improvement in efficacy or toxicity compared to the autologous collected CAR T. And the other thing is that off-the-shelf CAR T, even though it sounds like, oh, it's widely or readily available, it's not the case for every patient. So not every patient, there's still, these are donor CAR T cells that have been engineered and are kind of being available to be used. But they still have to go through a process of immune system matching, is what I would say at a very small level. There is the chance, so there's always the fear of something called graft versus host disease, where if you don't match correctly or you don't match to the absolute immunologic minutia, well, there can be kind of an unwanted effect of where the CAR T cells can recognize the patient's body as being foreign, or vice versa, the patient's immune system can recognize these CAR T cells as being something that's not supposed to be there. And there's kind of a battle that happens and you kind of shoot yourself in the foot. What I will say is that the technology has improved to where we're able to gene edit what we call HLA, or human leukocyte antigen markers on the cells, so that can be less of a problem, but it's more complex. And so I would say availability is not for all patients. And then number two, there are certain risks that have been mitigated with time, but still could potentially exist with off-the-shelf versus autologous. Autologous, if a person is able to collect, they will have their CAR T and they can get their CAR T because it's self versus non-self.
Great. Thank you, guys. I want to thank Dr. Ventura and Dr. Kosuri for taking time. This is fantastic information. I can just tell you that it is, for the most part, cutting edge. So I really appreciate them taking the time. Please fill out the survey, whatever, we do look at these and want to continue to improve the product. Linda has put in the chat, look at our upcoming support affinity groups. There's a full link in the chat or on the website. September 8th is Dr. Astia Alanzara, our next Ask the Expert webinar. And finally, last plug for MyoCon 2025. I know that Dr. Ventura will be worth the trip down to Dallas, Texas. She will be speaking more in depth on a breakout session about talking about myositis trials, first-person patient and physician perspective. So everyone, thank you very much. Stay healthy and enjoy the rest of your day. And hopefully the weather is nice as it is here in Chicago. So thank you.
Bye, everyone. Thank you.
All right, thank you.
Thanks. Bye.